okay? Right now, in illnesses where subsequent to a URI, people end up with cough that lasts anywhere between 4 and 12 weeks, the odds are you had pertussis. It's 1 in 10 cases of prolonged cough in the United States right now, and the Canadians are in way worse shape than we are. Let's talk about pertussis, because those of us that, you know, it was something I sort of thought was a dead disease, like diphtheria. You know, ooh, interesting, cool, you know, but it isn't even close to a dead disease. The thing about pertussis is that immunity wanes. Even if you got your full vaccination series when you were a kid, immunity wanes. Even if you got pertussis, immunity wanes. You can get it over and over again. It's not like you are now immune for life. It absolutely occurs. For those of us that are adults, it ends up being a significant inconvenience, but to a little kid, it can be life-threatening, particularly to a child under 6 months of age. We at Harbor are very good at this disease because we had a death in an infant that led to all of us learning about this disease, all of us learning about vaccination, all of us learning about treatment and approach, because it is a significant impact on little tiny kids. So let's talk a little bit about what it is, because for a lot of us, it's sort of a review. It's like, wow, what is this? You know, whooping cough. I remember that part. Pertussis equals whooping cough. But what is this illness? What does it do? So it's a bacterium. Okay, it's caused by a bacterium. It's gram-negative. It's Bordetella pertussis. That's the organism. If Billy were to cough on you right now with his runny nose and his potential pertussis illness, the incubation period from you getting hacked on by Billy to your developing symptoms is about a week to 3, 6 to 20 days. So you come to LA on the 3rd of April. Billy coughs on you on the 4th. You go home, and on the 16th, you develop a runny nose and watery eyes and a low-grade fever, and you just have a mild cough, like a cold. Okay, that's, you got it from Billy coughed on you. You think you got a cold from Billy. That's the incubation period time to developing symptoms. And that first window of symptoms is what's called the catarrhal stage of pertussis. And it looks like every other URI you've ever had in your life. The fevers are low grade, 100.5, the kind of thing you might not even really notice, it just don't feel so good. That will then evolve into what's called the spasmodic phase of pertussis. Now you are actually, you came here on April 3rd. You got sick on April 16th to 20th. You had a cold until May 1st, and now you start to cough, and you cough, and you cough. The characteristic, sort of prototypic cough, the thing that we read about in school, is 10 to 15 expulsions before you breathe. And that really does occur. You That's the whoop. Now, kids don't whoop as much as adults do, interestingly. Middle-sized kids tend to whoop. Little kids don't whoop. Little tiny kids may not whoop at all, and we may not even pick up the disease if you're looking for the whoop. But this spasmodic coughing can be profound. People can get cyanotic. People can get prolapse. People can get subconjunctival hemorrhages. People can get post-tussive vomiting, which actually, there was a guy in the conference that we did just 2 weeks ago, I was describing this disease, and he went, that's what my wife had. He said he'd come home one day, walked in the house, and heard this cough, 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 cough in the back of the house, and then this cough, cough, cough. He said, ugh. And she did this for weeks. He's like, that's what my wife had. She had pertussis. So that is the spasmodic stage. That lasts between 2 and 4 weeks. So now you're to the end of May. You have this awful, awful, awful cough. Then you convalesce. The problem with convalescing is the cough, it may not be quite as bad, but you will have a persistent cough for as long as 6 months. It's 1 to 4 weeks on average. It's as long as 6 months. So from Billy coughing on you on the 3rd of April, if he has pertussis and you get it, you're going to be sick until the end of June. You may cough until September. It's a pretty big deal to get pertussis. For us, again, it's an inconvenience more than something that kills us. But little kids can actually die of this. They can have respiratory problems. They can have neurologic problems. It causes some significant downsides in kids. Now, the good news is it's completely treatable. The bug, the bacterium, completely withers up and dies around Bactrim and around basically any macrolide. So you can whiff erythromycin in its direction, azithromycin, clarithromycin, Bactrim, and it just withers up and dies. That's the good news. The bad news is by the time you figure out you have pertussis, you can't treat it anymore. The only treatable phase is that first 2 weeks of symptoms when you think you have a URI. That's when you have the organism, Now the organism's gone, and the reason that you're coughing so much in that second stage is what it causes is your cilia to dysfunction and for you to slough respiratory epithelium into your airways. And you cough and cough and cough and cough trying to get it out of there. That's why you cough so much. By the time you get to that awful, obvious coughing spasmodic stage, you can't treat it. Horse is out of the barn. You can't treat it. Our goal would be to try to catch cases in that catarrhal stage, that runny nose stage. The problem is that it's like every other URI you've ever seen in your life. Now, can you diagnose this disease? Sure you can. 3 ways. You can culture it. You can actually grow the bug. It's a nasopharyngeal swab. It takes 1 to 3 days to grow. It doesn't require anything except letting your lab know you want this. It's not done routinely by any means. It, again, takes 1 to 3 days to grow, but it only grows during the catarrhal stage. Okay, that 2 weeks, first 2 weeks of illness is when you grow it. At that point, the bug is gone, the damage is done, you're now recovering through the spasmodic and the convalescent stage. At that stage, you can do some PCR testing, although it's usually better in the first 2 weeks as well, or serologies. So there are 3 ways to diagnose it. Grow it, first 2 weeks. PCR, best first 2 weeks, kind of drifts into that second stage. Serology is second stage to convalescent. Okay, and there's some definitions in there on how to actually, what is criteria for, yes, indeed, you had an acute pertussis event as far as serology is concerned, but we can diagnose this. We'll talk about actually what the best thing to do about this disease is as we go through the papers. Why is this even an issue now? Why are we even talking about pertussis? I mean, I've been in medicine for 23 years. Oh, 23 years, how scary is that? We didn't talk about this till recently. Why are we talking about it now? We have, pardon? Vaccine's part of the issue, and we'll come back to that because that is a big issue right now. The reason that this is something that we talk about is it does cause illness. It is miserable to have a cough for 6 months because of this. It's awful, it's miserable. 1 million cases in the United States, probably being reported more than truly occurring more, but if you're from Canada, their incidence is up between 10 and 30% of real new disease. So it is actually a true outbreak in Canada versus our probably is just a reporting issue. Now, it is still way better than it was back in the pre-vaccine era. In the pre-vaccine era, there were 50 million cases a year. Now we have 1 million cases a year. And in the pre-vaccine era, it was the little guys that got it the most and had all the bad stuff. Now it's us. Now it's adolescents and older people that get this disease. It's rarely little kids, and the ones that do get it that are little kids are the little kids that haven't had their vaccines yet. The articles, there are a couple articles in here that bring up just some interesting pieces of information. Abstract number 4 is a little bit frightening. Abstract number 4 is a Kaiser study. It took adults, ages 23 to 82, basically and looked at them for, if they had coughed more than 2 weeks, they looked at them for the risk of pertussis. They found 153 patients with these cough more than 2 weeks in this Kaiser study. Serology was positive in 19 of them, okay, of these 153 patients, so about 10 to 11%, pretty decent number there. Most of them had been immunized, so this was a waning immunization thing. This wasn't, wasn't somebody who just hadn't been immunized. This was somebody who went through all their shots and they just were no longer immune. And they had one particular patient, this one's kind of scary. One patient was responsible for transmission to her newborn, as well as to a mother and newborn sharing the hospital room with her after delivery. The mothers aren't going to die of this, but these newborns could. Okay, this is a significant issue. Abstract number 6 and 7 basically look at the fact that once you are symptomatic and have the cough, you don't grow the bug anymore, but your PCRs or your serologies may be positive. So again, the horse is out of the barn, you've had the infection, now you're having the sort of after effects of that particular infection. Abstract 8 is the one that says, yes, indeed, this is occurring more often in Canada. And abstract number 9 is helpful for those of you that are office-based. If you have an adult that comes to see you, may not remember their URI kind of symptoms, but just comes in and says, I have been coughing for 3 weeks. I've been through 16,000 courses of antibiotics, nothing's working. I've been coughing for 6 weeks. I've been coughing for 9 weeks. What is the deal? We're going to ask about ACE inhibitors, because that's a big cause of cough. But if you test them serologically for pertussis and it comes back positive, it stops all your further testing. You don't really need to do anything more for that patient. And by the way, if you've ever had pertussis and you've had the cough that lasts and lasts, there's not a lot that works for it. Okay, inhalers hardly ever work, cough suppressants hardly. It's just one of those things where all of our armamentarium for cough doesn't really work.
Does it help if you like that?
Say it again? No, actually it doesn't. No, because it's not a bronchospastic issue. It's a cilia dysfunction and a sloughing issue that makes people cough so much. So it's not really bronchospasm, and they don't really wheeze. They just cough and cough and cough and cough. And it's just basically trying to get out this sloughing epithelium in the airways is what the issue is mainly. Yeah. The little guys don't, yeah.
Do they tend to have the coughing spasms?
They do, and actually one of the things that should clue you in at a little kid is the coughing and they barf. Now a lot of kids do that, well not like, I think kids have done that a lot in our experience, and I think what we're finding is that a lot of those kids are pertussis kids. Usually. One of the things, make sure this is correct before I say this, one of the things that they tend to do is have a very high platelet count with pertussis. So look at your platelet count as well. It's just another sort of, it's not uniform by any means, but it's a clinical clue. It's like if you get a it's like, whoa, what the heck is this platelet count? It's like, recent URI, coughing like crazy, high platelet count, this is probably pertussis. Now, the other thing, by the way, if you take care of kids, go ahead.
Is there a preference for PCR versus serology based on how long they've had their cough?
Yes. The longer they've had their cough, the more you're just going to default to serology. The PCR tends to be positive earlier in the illness, but if you get somebody who is now 8 weeks in, you're going to want to get serology. That may be the only test. In fact, I wouldn't even remotely send a culture in somebody who's more than 2 weeks into their illness. It won't be positive. It's a lot of money for nothing. That's when the serology is helpful. And this serology really just basically says, this is what you had, kind of a drag. We'll try to treat you and get you through this, but plan on coughing for a while. So, yeah, it's Oh, exactly. And we'll talk about sort of exposures, too, at the very end of this section, because exposures are a significant concern, especially for healthcare workers. For us, it's a significant concern. Now, those of you who take care of kids who have ALTI, apparent life-threatening events, which are children under the age of 1 who have an episode of unexplained apnea, coughing, choking, change in muscle tone, or a change in mental status. Little guys that have something funky happen at home. If you do a full-on workup for ALTI, abstract number 11 is the one that sort of looks at this, 9% of these children, it turns out to be pertussis that's the issue. So look for pertussis in these little guys that get an ALTI episode. This is actually the kid that died at Harbor was an ALTI kid, had an ALTI episode, was worked up, sent home, and then came back really sick and died of pertussis. And it was probably pertussis that had caused the original ALTI episode. So it's worth looking into. If the problem is, by the time we see people, the horse is out of the barn and we can't treat them, we can say, guess what, your serology is positive, you're going to cough for a while and nothing's going to work. What we'd like to do is just prevent the thing. And this is where the mention was made of the vaccine. Up until now, we did not have a vaccine for adults for pertussis. There was not a vaccine that was effective or safe for adults. There is now. The Acellular pertussis vaccine was released relatively recently. It's called the Dtap. So for adults, we usually are used to giving a DT, small d, large T, for wound prophylaxis is what we give. What you can do is now switch to a Dtap, okay, which is basically includes the AP is Acellular pertussis vaccine. Pardon? Well, that's one thing. For one thing, it's in short supply because everybody's jumping on this bandwagon. The other thing is it's about double the cost. Those of you that work in your offices, you guys usually order these yourselves and you have to pay. My understanding is it is double the cost. Charges may be different, but the actual upfront cost is twice as much to use the Dtap on this. A couple things about it so that you know. There are 2 kinds. One is approved for people from ages 11 to 18. The other one is approved for people ages 11 to 64. One is 10 to 18. It's easiest to just grab the one that's approved for the bigger age range. It has not been proven safe for people over the age of 64. So for those of us that work in the emergency department, if you are considering switching your DTs to Tdaps, you can't throw DTs away. Okay, you still need to keep them around for the 84-year-old who scrapes their arm and gets, an injury and needs to be prophylaxed. It has not been approved for people over the age of 64. So it's a little more expensive. What we'd like to do, though, is prevent people from getting pertussis because it's a pretty debilitating disease. The recommendations for using it are in abstract 14. It's the CDC recommendations now. If you get a child who's been through their full immunization series and they are now more than 5 years past their last immunization, you can now use a Dtap, or Tdap, to add their tetanus prophylaxis from there on out. Okay, 5-year is the sort of window that they recommend giving this. It's a single dose. They recommend now. They don't recommend boosters yet. They're getting there. It's an alternative for DT for wounds. It's safe in pregnancy, and it's not to be used in children under the age of 10. Okay, so that's the CDC recommendations. Does it work immunogenicity-wise? Does it generate an antibody response? Abstract number 15 says, you bet your life it does. If you get a Dtap vaccine, the immunogenicity rate is over 98%. You will have measurable antibodies to this over 98% of the time. Yay. So it works as far as your immune system. The next thing we'd like to know is abstract 16 is, okay, fine, my immune system gets boosted. Does it prevent my getting the illness? The answer to that is also probably yes. The problem with abstract 16 is there are so few cases in this particular paper. It's a little hard to say absolutely it prevents it, but it looks like it's about 92% effective in preventing illness. So you get antibodies most of the time, and 90+% of the time it will prevent your getting the illness itself. So it's good. It works. Very little downside to this. Local stuff is really the only issues you have as far as the shot's concerned. The bigger issues that come out, I mean, the reality is if it were cheap, we should all just be giving this routinely. The issues that come up are things that come up in sort of abstract 17 and 18. I'll talk about exposures as well. Should we be giving this in the emergency department? What if the insurance company won't pay? Is the patient supposed to pay? Do we suck up the difference if they won't pay? Should we be doing this routinely? Should we as an institution? My husband is a medical director of an ER in Colorado. And they've just basically, the hospital has committed themselves to this. They switched all of it over to the Tdap, except for people over the age of 64. The hospitals just said, we'll do this. If the insurance balks on any individual case, fine, we'll suck it up. We think it's appropriate to do for public health purposes. It does bring up some issues there. And what if you get exposed? Like we had this kid that died of pertussis. All of us that had taken care of this kid who died of pertussis all had been exposed to pertussis. Now, theoretically, if you are past the catarrhal stage, you are no longer infectious. Okay, if you're just coughing, 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 and you're just in that spasmodic stage, you're not infectious. But if you're exposed in that runny nose Billy Mallon stage, you are infectious. What if you get exposed as a healthcare worker? What are you supposed to do? Well, a couple of things. The recommendation for healthcare workers exposed is that you are prophylaxed. Okay, especially if you have children at home, you are not to work until you've had antibiotics on board for 5 days. If you develop symptoms, you stay home until you've had antibiotics for 5 days. So you're not supposed to work and you can spread this disease. Now, I am willing to bet you $100 if you go back to your hospital, those of us that are hospital-based, you have no protocol for this. I will bet you $100 if you go down to your public health or your employee health department, they have no protocol for pertussis exposures. They just don't. It's worth looking into, especially if you have a case of pertussis that develops. The other thing is if you have children at home, if you have little guys at home under the age of 3, and you think you've been exposed to pertussis, I recommend that you take antibiotics on your way, when you go home so you don't expose your kid to this. If you decide to vaccinate, by the way, abstract number 19 outlines basically a federal law called the National Vaccine Injury Act of 1986. That is it's actually the swine flu is kind of what popped this thing to happen. If you decide to give the vaccine, one of the things our nurses have said is, I don't want to give this. I'm putting my license at risk. What if the patient gets some bad side effect? I'm putting my license at risk. This act basically protects all of us if you follow CDC recommended guidelines on immunizations. It has a fund that's been set up to help take care of people who do have vaccine-related things that occur. So that it has that as part of it. This vaccine is covered under that, as is the Hib vaccine, the hepatitis B vaccine. All these things that we do routinely are covered under this act. The parts of it, though, you have to do a couple of things. You have to, on the chart, date the administration of the vaccine, put down the manufacturer and the lot number of the vaccine, and the name of the person who administered it. That's just a way to track it. And if you think you have a vaccine-related injury or illness that occurs, you need to report it. And there's a hotline number to call. It's very easy to do. So that's the deal. Any questions on pertussis? It's very interesting. I have to tell you, one of the things that I think now that we're getting this vaccine is available for healthcare workers, I think it is worth getting the Dtap. It's one of those, or the Tdap. It's one of those things where I get colds 2 or 3 times a year. I mean, in the ER, you're immersed in bugs all day long. And I work with kids. So I would hate to give a 3-month-old pertussis when I have my cold at work, but it turns out to be pertussis. So I think it's worth our getting. I think we're actually talking to our employee health department to make it now the next set of vaccines for required for healthcare workers. I know my husband's hospital has done that. was a hand over here? No, yeah.
If your PCR is positive, you still get the vaccine.
Oh, that's a very good question. I'm not sure. Does anybody know who uses this more often? I'm not sure. My gut reaction would be no. Because if your PCR is positive, you are going to develop immunity because you got hosed, because you got the illness itself. But I'm not sure about that. That's a very good question. I don't know. I'll see if I don't have my computer with me, but I'll see if I can look it up for you online and see. Yeah.
We had a nurse that had it in our enrolled who still didn't get that.
So even though she was positive PCR-wise, that he still gave the vaccine? Yeah, I'm not sure if there's a recommendation specifically on that. So I don't know. All right, let me go.
Somebody
Yeah.
comes in with a chronic cough.
Uh-huh.
Doing the lab work. If you go ahead and treat them like asthma, they don't respond. You need to say, well, very likely you have pertussis. Because some people have, post some kind of infection, have a bronchospasm.
Mm-hmm. Mm-hmm.
So is that way of clinically kind of, not exactly, but saying, well, maybe the reason you don't respond is because you have pertussis?
Maybe. I think the clearer if you really wanted to make a clinic, we just had a case of this in the ER like 3 days ago. If you wanted a clearer diagnosis, it would be, I had a cold a month ago. It was no big deal. I've been coughing ever since. I cough sometimes till I throw up. It's like, okay, well, that one's pretty easy. There aren't too many illnesses that make you cough till you vomit. And pertussis is one. If they're wheezy, I think it's actually even a little less likely to be pertussis. So wheezing does not typically occur even in the spasmodic stage. Yeah.
So what do you do now that you have all these people coming in with URI type symptoms, and in the ER you see them once, you don't see them ever again until they're back in the whooping stage. You can't do anything about it.
Exactly. I honestly think we're not going to diagnose this early.
The pediatric guys are going to yell at you for getting over the
No, and I wouldn't. I mean, if you think about it, if we have 1 million cases of pertussis a year in the United States, we have 300 million people, and we probably have 150 million URIs episodes a year in this country, you're going to be treating a needle in a haystack. You're going to be treating less than 1% of the URIs are truly pertussis. Even though there are 1 million cases sounds like a big deal, think of the whole sort of set of URIs that occur out there from just viral stuff. I think you don't go charging ahead with this. I think that truly the approach to this that's best is to vaccinate. Get as many people vaccinated as we can ultimately. The only other concern though is if there is someone, if it's a new mom who has an infant and she just is not feeling so great, especially if she's been exposed to somebody else who might have had pertussis. God, my husband has this terrible cough now and he had a runny nose 2 weeks ago. That may be somebody you want to actually test and treat so that the child isn't exposed. And this is, again, there are a whole lot of URIs, and to go chasing which of those URIs are pertussis I don't think is the take-home point here. I think the take-home point here is to vaccinate. Yeah.
Is there any aggressive movement by the CDC to have monitoring programs to try and pick it up?
Not that I'm aware of. Not that I'm aware of. Actually, the head of the CDC was my chief resident when I was a medicine resident, and so I keep up on this because it's kind of fun to follow her career. And I've been looking at this topic, and I haven't seen any surveillance other than intermittent sort of spot checks to sort of see what our prevalence rate is. But as far as individual case approach, no.
We tried real hard to get the Dtap put in our hospital. We had that one nurse that did test positive.
Yeah.
And to no avail. And we went to, as far as showing the hospital in Houston that was
Why didn't they want to?
the cost.
It always comes down to bucks, doesn't it? Yeah. And I think, to be honest, if I were a bean counter, I'm up there saying, how much money is it going to cost me to vaccinate my whole ER, and what's our bad outcome here going to be that's going to cost the hospital if we don't vaccinate people? If you're a bean counter, money-wise, it doesn't make sense, unless you have one case where a kid dies and they sue the nurse that they think exposed them, but that will never go anywhere. So, I mean, bean counting-wise, until the CDC says vaccinate all healthcare workers, we're going to have some trouble. Yeah.
If you have a fully vaccinated population, at what age do you start worrying that this cold is pertussis? And then, in other words, cold.
Adolescence. The group that the peak goes up again about the age of 16, so at the end of high school, and then college age, absolutely. That's what you wane at about 5 years is where you start to wane your immunity. So they've gotten their last set, they hit it into high school, into college, and that's where the risk starts to go up. And that's the group that is a pool, as are we, healthcare workers and older healthcare workers, yeah.
Are you vaccinated every 10 years now?
They actually don't, right now it's a single shot and 5 years since the last set. They haven't given recommendations yet on how often to give this. Again, right now that we're in the sort of go for that first one. They haven't yet looked at when the true immunity wanes from this enough to have to, is an anamnestic response going to be enough? Where does it really go away enough? You need to boost it with an immunization. And that one they haven't recommended yet. I think they're going to come down to Q5, is what it looks like. Yeah.
A little off subject, but terminal illness in college students. Have we started to see any increase in chickenpox or anything like that in that age group?
I just read something about chickenpox like yesterday. No, that was on immigrants, whether we should be immunizing all immigrants for chickenpox. That was the other thing I was reading. This is trying to sort through the hard drive here. Failures, exactly. I'm not aware of that, but I don't keep real close track of the varicella. But it does wane. It's not a perfect vaccine. It doesn't keep you for life like getting the illness does, which is kind of interesting.